Hello, today we're going to talk about disease-modifying therapies for Alzheimer's disease. Here are my disclosures with NIH funding as well as my involvement in clinical trials in Alzheimer's disease. So, in the past several decades, our treatment for Alzheimer's disease has focused on a symptomatic therapy, which has been primarily cholinesterase inhibitors and memantine. And the dashed line here in the figure represents symptomatic therapy, where we can see a modest improvement in symptoms and then ongoing decline. Our efforts in clinical trials in the past 2 decades have focused on disease modifying therapies, trying to slow down the progression of symptoms. So, multiple trials have looked at mild to moderate to AD dementia and have not shown benefit. And so, intervention prior to dementia and prior to widespread irreversible brain cell loss may be better in terms of slowing progression of disease. And so, we have moved to earlier stages of disease. In other fields, such as oncology, cardiovascular disease, infectious disease, we don't wait to treat patients until after their symptoms appear. And in fact, just delaying dementia by 5 years could reduce projected costs by nearly 50%. The first disease modifying therapy for Alzheimer's disease, aducanumab, received FDA accelerated approval now 2 years ago in a controversial decision, which we'll discuss later. Then, much more recently, earlier this month, in July 2023, lecanemab received FDA full traditional approval, and we'll discuss that further as well. So just to review some of the work in clinical trials the past 2 years, 20 years, we've primarily focused on amyloid therapies, and a lot of the focus has been on immunotherapy, which will be what we'll discuss primarily today. But we have also looked at other modalities of influencing amyloid, in particular BACE inhibitors and gamma secretase inhibitors that reduce formation of amyloid. Unfortunately, those have not been effective and have also had significant toxicity, and so have fallen out of favor. Also, reducing aggregation of amyloid has not shown significant benefit and has fallen out of favor. More recently, targeting tau has been a focus as well, and we'll give some examples of that later in the talk. Aside from disease modifying therapies, clinical trials have also continued to focus on symptomatic approaches, focusing on both cognition and neuropsychiatric symptoms. Occasionally, there are more novel mechanisms, such as neuroprotective agents or anti inflammatory, antioxidant agents, that are being explored. As I mentioned, our focus will be on immunotherapy because a lot of the trials that have been done and the most recent FDA approvals have been with these agents. And so initially, we looked at active vaccines against amyloid, as depicted in the left side of this panel, basically introducing an aspect of the A beta peptide into the individual and then triggering the development of antibodies against amyloid. On the right side, the panel depicts passive immunization where antibodies are developed in the lab and introduced into the individual and then try to target amyloid. So the first active vaccine, AN1792, was tested about 2 decades ago, and unfortunately did not show benefit, but also caused significant side effects, with 6% of participants developing meningoencephalitis. This particular vaccine targeted the full length of the A beta peptide and was tested in individuals with mild to moderate AD dementia. And so, as a response to this, new active vaccines were developed that were targeting only a shorter snippet of the A beta peptide than the N terminal. And these are two examples of this. Unfortunately, even though they proved to be much safer, they did not show clinical benefit and their development has been stopped. So at the same time, passive immunization has become a bigger target. And there was an early attempt to use pooled immunoglobulin as a treatment. And unfortunately, a phase 3 trial did not show benefit at the stage of dementia. So the mainstay has been monoclonal antibodies generated in the lab, and there have been a variety of these antibodies out there and multiple trials. There have been, unfortunately, multiple phase 3 trials that have not showed benefit at the stage of mild to moderate dementia, and some at the stage of mild cognitive impairment or even preclinical Alzheimer's disease. However, more recently, there have been some successes, and there was the accelerated approval of aducanumab, which we'll discuss in a moment, and then much more recently, lecanemab and donanemab with full approval for lecanemab and donanemab requesting full approval from the FDA. And so here's a summary of these particular anti-amyloid antibodies. And you can see that some of them target soluble amyloid, some insoluble, and some a mix. And so solanezumab targets the smallest snippet of amyloid, a monomer, which is soluble. And on the other end of the spectrum, donanemab targets whole plaques that are insoluble. And then in between, you can see that uh, agents like lecanemab target soluble later stage amyloid, and then bapineuzumab and aducanumab target a mix of soluble and insoluble amyloid. So let's discuss aducanumab. And so there are two phase 3 trials that were completed that led to the accelerated approval by the FDA now 2 years ago with a revised indication for individuals with mild cognitive impairment or mild AD dementia. However, the results were not straightforward. So these were two identically designed trials, and the execution was slightly different, but still very similar trials that were completed. On the left, the eMERGE trial, showing us here the clinical outcomes, showed a benefit of modest slowing of decline in the primary outcome CDR sum of boxes, so a global cognitive and daily functioning measure. So a reduction of about 23% slowing of decline over a period of 18 months. However, with the high dose and the engage trial, this was not replicated. The drug arm was essentially the same as placebo. And so there wasn't a clear clinical benefit because these two trials that were done simultaneously had opposing results. On the other hand, the biomarker signal, in this case, removal of amyloid as measured by PET scan in the brain, was very clear, and it was for both low and high dose in both trials. You can see a significant removal of amyloid from the brain as measured by PET scan. To complicate things, what we've seen with this class of drugs, and certainly with this drug aducanumab, is that there are amyloid-related imaging abnormalities, or abbreviated as ARIA. ARIA-E refers to vasogenic edema or sulcal effusions, as depicted on the left side here. So you have here area of vasogenic edema and FLAIR images, and here sulcal effusions. And also we've seen ARIA-H referring to microhemorrhages, as depicted here in various spots, as well as superficial siderosis here. Um, and so these side effects were quite common with aducanumab. 35% of the individuals receiving the high dose, 25% low dose, developed ARIA-E versus only 2.5% of placebo. And so this required frequent monitoring with MRI to make sure that we capture these side effects because only about a quarter of them cause symptoms. So aducanumab in the U.S. Was not covered by insurance despite this accelerated approval. It did not receive full approval, traditional approval from the FDA. Medicare determined in April 2022 that it will only cover it as part of a clinical trial. And in fact, a third phase 3 trial was launched, the Envision trial, last summer, a year ago, to try and provide this additional information and potentially point us either in a positive or negative direction as a final trial looking at aducanumab. Let's switch gears and talk about donanemab. So this is data from the phase 2 trial of donanemab Trailblazer, focusing on the clinical outcomes. This trial was in individuals with mild cognitive impairment or mild AD dementia, and like aducanumab, required elevated amyloid in the brain for entry, but also required elevated tau at an intermediate stage, so not too low, not too high, trying to target individuals who have some tau in their brain. And with those inclusion criteria, what we can see across these different clinical measures is that there was about a 30% slowing of cognitive decline and daily functioning decline over an 18-month period. Additionally, individuals who became amyloid negative in the trial were taken off of drug, and we see these results even in the individuals off the drug. And here we see the biomarker results with, again, PET imaging of amyloid, showing us a robust removal of amyloid. Even as early as 6 months, 40% of individuals became amyloid negative. And by 18 months, the majority became amyloid negative. Um, at the time, there was a request for accelerated approval that was submitted to the FDA, but they declined it in January 2023. So then followed the phase 3 trial of donanemab, Trailblazer-ALZ 2, which had a larger group of about 1,700 participants and a primary group of about 1,200 participants, uh, resembling the phase 2 trial, where there was elevated amyloid and intermediate, low to intermediate tau in the brain. The larger group included also individuals with high tau in the brain. So the primary analysis focused on the individuals with low to intermediate tau in the brain, and the results were initially reported in May, and then most recently comprehensively discussed in a conference and published, and showing us that there was a significant slowing of clinical decline over 18 months. So ranging from 32 to 40%, depending on the clinical measures that were looked at in these individuals who were in this primary analysis group. When looking at the entire cohort that included people of high tau, the results were still significant, but they were attenuated, suggesting that earlier in the disease process can make a bigger difference. Um, and similar to the phase 2, we saw that a significant number of individuals became amyloid negative by 6 months, 34%, by 18 months, 80%. Like aducanumab, there was a high rate of ARIA-E, so 24%, and 6% were symptomatic, and 1.6% seriously symptomatic. ARIA-H was common, but when looking at ARIA-H in isolation without ARIA-E, it was the same rate as placebo. Macrohemorrhages were rare at 0.4%, and infusion reactions occurred at 8.7%. So with these results, there was submission to the FDA for full traditional approval, which is being reviewed in the next 6 months. So here we depict the primary results, clinical results. On the left, there's a combined measure of cognition and daily functioning in panel A, and the main analysis showing us over time slowing of decline that becomes a little bit bigger comparing the placebo to drug. On the right, we have the entire cohort where the results are low attenuated. And here is another measure of the CDR sum of boxes showing us a slowing of decline in the primary analysis and a little attenuated in the main and the larger cohort. Here we have biomarker results, and we have the amyloid results on the left here for both primary group analysis and larger cohort. Nearly identical, robust removal of amyloid from the brain. And then on the bottom two panels, we have measurement of phospho-tau in the plasma, and showing us that in both cohorts, the main cohort as well as the larger cohort, there was reduction of tau. Let's switch gears and talk about another monoclonal antibody, gantenerumab. There are two large phase 3 trials that were completed in a similar cohort of MCI mild AD dementia with elevated amyloid. Unfortunately, did not show clinical benefit and lower than expected amyloid removal. And so, unfortunately, this particular drug is no longer in development. And this was presented about a year ago. Now, I just want to mention some examples of prevention trials. Initially, looking at individuals with genetic risk for Alzheimer's disease, autosomal dominant mutations of Alzheimer's disease that are quite rare, accounting for only about 1% of cases of Alzheimer's disease. And the Diane TU protocol brought all comers of these autosomal dominant mutations and included both asymptomatic individuals and symptomatic individuals. Looked at two different drugs and monoclonal antibodies, solanezumab and gantenerumab. The trial lasted several years, an average 4 years. Unfortunately, did not show clinical benefit. There was some target engagement, but as mentioned before, gantenerumab, the phase 3 trials and sporadic AD did not show benefit, unfortunately. Then this prevention trial was the Alzheimer's Prevention Initiative, a trial that looked at one particular variant of the preselenium-1 autosomal dominant mutation in a kindred in Colombia, um, and was purely in asymptomatic individuals. Was a 5-year trial, actually ended up being 6 years. Used crenezumab that targets soluble amyloid. Unfortunately, did not show benefit either, and no target engagement. Hopefully, another trial will be done with this cohort, as will be with the Diane TU cohort that's already being planned. Next is a prevention trial based on biomarker risk for Alzheimer's disease. The first of this kind, anti-amyloid treatment in asymptomatic AD, or A4 study, which was launched nearly a decade ago, included over 1,100 participants who were cognitively asymptomatic and had elevated amyloid in their brain based on PET scans. These individuals were 65 to 85. The trial, double blind, was 4.5 years and followed by an open label extension. The drug that was looked at was solanezumab. Early on, the dose was quadrupled, seeing that the results of phase 3 trials in people with dementia did not have a benefit with the original dose and that it was safe. And then the primary outcome was a cognitive composite. There was also a companion observational study, the LEARN study, that was for individuals who screened for the study who had low amyloid in their brain. The trial was completed in December of 2022. We'll review the results in a moment. This is just to show you the enrollment process. So over 15,000 people were contacted by phone or on the web, and nearly 4,500 individuals underwent amyloid PET scans to end up with the over 1,100 participants in the drug trial and over 500 participants in the observational LEARN study. All this data at baseline became publicly available, and several publications have already been made. So for the actual results, which were initially announced in March and then more thoroughly discussed in July and published, unfortunately, there was no clinical benefit. And so you can see in the primary outcome here in the graph that on the clinical composite, a cognitive composite, there is no difference between the solanezumab and placebo arms over the 4.5 years, which was the main analysis, and a little beyond that, which was extended because of the COVID-19 pandemic. The biomarker results also did not show a benefit. Solanezumab did not clear amyloid and didn't reduce the accumulation over time. It was similar to placebo, that both in the placebo arm and solanezumab arm, there was an increase in amyloid accumulation. It was a little less in the solanezumab arm, but both arms had an increase. Moreover, we looked at, for the study, progression to fourth stage of clinical disease, and with, in this case, the CDR global measure progressing from 0 to 0.5 for at least 2 time points, and about a third of participants in either drug or placebo arm progressed over that time frame of 4.5 years to a stage equivalent to mild cognitive impairment. And having higher baseline amyloid did predict worse progression over time. The safety profile, similar to the 3 phase 3 trials in dementia, was very good. So there's essentially no ARIA, same rate as the placebo, and very little adverse events different from placebo. And then longitudinal data for both the A4 drug trial as well as the Learn observational study will be publicly available in the next year. So a similar prevention trial that's ongoing is Trailblazer-ALZ 3, which uses donanemab, which we discussed recently, the phase 3 trial in mild cognitive impairment, mild dementia, showing benefit. In this case, 3,300 participants are being recruited. These are going to be cognitively asymptomatic and will have elevated plasma phospho-tau as their screening biomarker. There's a very high correlation between plasma phospho-tau and amyloid PET. And this is, of course, much easier to do than getting PET scans on all the participants. Primary outcome is the CDR sum boxes. The duration is 3.5 years, and this trial was launched 2 years ago, and hopefully enrollment will complete soon. Let's switch gears and talk about lecanemab. And so this is the phase 2B trial that was a dose-finding trial, 5 different doses. This is another monoclonal antibody against amyloid. This was also an MCI mild AD dementia participants with elevated amyloid. And what they found is that the 2 highest doses had the potential benefit. Here are the clinical outcomes showing that the highest dose showed some modest slowing of cognitive and functional decline. And here are the biomarker results with amyloid PET showing that both the highest and second highest dose robustly remove amyloid from the brain. With this data, the FDA granted accelerated approval in January of 2023. And then phase 3 trial was completed shortly before that and presented to the FDA later and presented to the public and November of 2022. This was a trial, the same type of cohort of MCI mild AD dementia with elevated amyloid, nearly 1,800 participants, and they had typical exclusions based on pre-existing microhemorrhages or macrohemorrhages. They did allow individuals to be anticoagulated, and there was a one-to-one drug versus placebo arm, and they used the highest dose that was from the phase 2B trial. So the primary results, so on the left here, you can see several of the clinical measures. On the top panel, the primary outcome, the CDR sum boxes, there was a 27% slowing of decline over 18 months. And then similar results in panels C, D, and E for different clinical measures. Panel B here is the amyloid PET results showing us robust removal of amyloid over 18 months and as well as early as 6 months, similar to the donanemab results. In terms of adverse events, so the most common were infusion reactions. About a quarter of participants had infusion reactions that were mostly mild to moderate. About 12.5% or 12.6% had ARIA-E, which was higher in ApoE4 carriers, similar to other drugs in this class. ARIA-H in isolation was the same in drug versus placebo. Macrohemorrhages were rare at 0.6%, but more common if anticoagulated at 2.4%. With this data, the FDA recently, earlier this month, granted full traditional approval for the drug, which this is the first disease-modifying therapy for Alzheimer's disease to be granted full traditional approval. And so what are the implications of this landmark decision by the FDA? First, the cost of this drug is expensive, $26,500 per year in the U.S. Medicare did indicate in the U.S. that they will cover the drug in a clinical setting, unlike the accelerated approval scenarios where they decided to only cover a clinical trial. For this full approval, they said that they will cover it in a clinical setting, only requiring a registry with a minimal data set to be reported to Medicare, but not actual participation in the clinical trial. Arguably, our healthcare system is not ready to cope with the challenges and demands of a drug like lecanemab. Determining amyloid status for eligibility, either by PET or CSF. CSF in the US is covered by insurance, PET is not yet. Hopefully will be with this result, but again, requires a lot of resources. ApoE testing for risk stratification. This is something that also is currently potentially not going to be covered fully. And then just doing infusions every 2 weeks of this drug is something we're not used to for this many patients, and also requiring multiple MRI scans to monitor for ARIA. And then who is going to do these treatments? Specialists initially will probably have to determine eligibility, administer the drug, and monitor for adverse events. And there are not enough specialists in this area, and so we need to figure out a lot before this could be used in a large scale. So I'm just going to mention a prevention trial that uses lecanemab, the AHEAD study that was launched now 3 years ago, looking for 1,400 participants who are cognitively asymptomatic, older adults aged 55 to 80. There are two arms to the trial. So individuals with high amyloid, similar to the A4 study, and then individuals with an intermediate amount of amyloid, so a lower amount of amyloid to be an earlier stage of disease. That's a smaller trial that has a biomarker outcome. As part of the screening for this trial, before undergoing an amyloid PET scan, there will be plasma A beta measurements and now also plasma tau. And the drug is lecanemab, as mentioned, and for the high amyloid group, the first 2 years they'll receive the highest dose that was used in the phase 3 trial for cognitively impaired folks, and after 2 years moved down to one lower dose, which was the second highest dose in the phase 2 trial. The group with intermediate amyloid will receive that lower dose for the whole 4 year period. Um, so I'll end by talking about tau. Tau agents have not been explored as much, but in recent years, there was a first generation of tau antibodies, monoclonal antibodies against tau that are supposed to reduce transsynaptic spread of tau and are given intravenously. There are four phase 2 trials that were completed, and three different drugs. Three of the trials were in MCI and mild dementia, and one trial was in mild to moderate AD dementia. Unfortunately, none of them showed benefit except for the one trial in mild to moderate AD dementia, which showed questionable benefit or partial benefit. The one outcome was a global cognitive measure showing that at the very last time point at 12 months, there was a little bit of a difference. That's hard to know what to make of because prior time points did not show any difference between drug or placebo. And then unfortunately, the daily functioning measure didn't show a difference. And for the stage of mild to moderate dementia, we generally like to see both cognitive and daily functioning benefit. And so this drug is not going to be developed further. And so this first generation of tau antibodies did not prove to be effective. There is a next generation that's starting to be tested in phase 2, and there are other type of tau agents that are being looked at. And so hopefully we'll see some success with tau as well, and more success with amyloid agents for disease modifying therapy. And on that end, I will stop and we'll be happy to take any questions. Thank you very much for your attention.